This slide is from Calgary Guide to Understanding Disease. It is a student-written, faculty-reviewed publications, information, and website. The great thing about this is that all of the information is up-to-date, research written by med students. It is collaborated with the University of Calgary Medical School in Canada. Their information has been published in their own books and used in medical schools and published in books as well around the world. What is interesting about this slide is that it gives a nice visual and flow chart of everything that happens to prevent when our patients have myocardial infarction. Take a minute to look it over, as there is a lot of information. This is a great source, as the chart is even color-coded and broken down into pathophysiology, mechanisms, signs, symptoms, and lab findings, as well as complications that arise when a patient has MI. Depending where the blood flow is restricted, it is what is affecting the heart, electrical activity, and pumping functions. When there is a sudden coronary obstruction caused by thrombus formation over the rupture of ulcerated atherosclerotic plaque, acute coronary syndrome results and includes unstable angina and myocardial infarction. Unstable angina is the result of reversible myocardial ischemia and is a hard binge of impending infarction. MI results when prolonged ischemia causes irreversible damage to the heart muscle. Cellular injury occurs when there is ischemia or lack of oxygen to the tissue. After only 30 to 60 seconds of hypoxia, EKG changes are visible. Oxygen deprivation, also accompanied by electrolyte disturbances, specifically loss of potassium, calcium, and magnesium from cells. Myocardial cells also release catecholamines, epinephrine, and norepinephrine, predisposing the individual to serious imbalance of sympathetic and parasympathetic function, irregular heartbeat, and heart failure. Norepinephrine elevates blood glucose levels as well. Angiotensin II, is released during an MI and results in systemic effects of peripheral vasoconstriction, fluid restrictions, and coronary artery spasms. Ischemic injury can be exacerbated by perfusion injury. Once blood flow comes back to those cells, there is a release of toxic oxygen radicals, calcium flux, and pH changes that causes sustained opening of mitochondrial permeability transmission pores and contributes to instant cellular death. Infiltration of inflammatory cells contributes further to tissue injury. The infarcted myocardium is surrounded by zone of hypoxic injury, which may progress to necrosis, undergo remodeling, or return to a normal state.